Welcome, Mario, to Palliative Perspectives. Today we're going to talk about aged care and specialist palliative care and where does it fit in aged care. So Mario is clinical nurse consultant here at GV Hospice and the current lead of our aged care project. So Mario, when we talk about specialist palliative care referrals in aged care, how do we explain the difference between a generalist palliative care and specialist palliative care?
So generalist palliative care is basically provided by just the guys working in aged care. So I'm thinking people who just gradually get older and deteriorate before they get end of life. Specialist palliative care comes in when there's symptoms that are concerning, that they are finding hard to manage. Sometimes it's pain, sometimes it's nausea, and depending on what the conditions of the patients are. So if someone's got a cancer diagnosis, they might face different symptoms as opposed to someone who's just got dementia and is just generally getting older.
Mm-hmm. So do you have to have cancer to have a referral to GV Hospice?
No, you don't. You have to have a life-limiting illness.
Mm-hmm.
Dementia is per definition the leading cause of death now in Australia.
Mm-hmm.
And dementia can bring with it some quite complex symptoms. So someone with dementia with complex symptoms definitely fits the bill. But someone who's got dementia, who's got no complex symptoms and is just generally declining, stopping eating or eating a lot less, losing weight, they don't all need to be referred to GV Hospice.
Okay. So what situations or circumstances or indicators in aged care are suitable for specialist PAL care?
Basically anything that the GP is uncomfortable or has trouble managing.
Okay.
So someone with, say, we'll use pain as an example. So someone's got pain and they've tried some analgesia and those sort of things, and the GP is really just not sure where to go from here. That's enough reason to either give us a call and have a chat about it or do a referral.
So should we as specialist palliative care have a low threshold for accepting referrals in the aged care space, do you think?
We do need to have, and we have had a low threshold for the referrals. Not everyone, though, needs to be referred. Yeah. So we need to have some investigation skills when we do get a referral, either via phone call, looking at their notes, because we have access off-site access to a lot of their notes. Have a chat to the GP, have a chat to the staff and say, like, what are you worried about? Mm-hmm. So, but instead of, we used to ring and ask, have they got specialist palliative care needs? And most of the time they would say no. But you're asking someone to give an opinion on something they have no training in.
Absolutely.
So hence we've been doing a lot of consults or just to visit and say, well, we'll just have a look at them. And if there's really not a lot going on, we can make some recommendations for the GP. And then
so it might be a once-off.
Might be just a one-off.
Or it might be ongoing.
It might be ongoing, yeah.
And so the low threshold is really about developing relationships with the aged care facilities, the staff, I imagine, as well.
The staff, the management of the aged care facilities, and relationships with the GPs as well, so that they know that they can ring us if they're not sure, or often the GPs are not sure what sort of end-of-life medications when it comes to that, to script and what to look for, how to decide, to go whether a morphine or a hydromorph or a fentanyl. They're really unsure, and the doses and those sort of things. So
and
we
there's
can
a lot
provide
of
guidance
to consider.
There is.
Into which opioid you would use.
Yep.
Yeah. So how do we as specialist palliative care providers support our generalist palliative care providers in recognising the last days or even the last year of life?
Lots of education. So we've developed some education about the deteriorating residents and subcutaneous medications. Mm-hmm. So I've spent a bit of time last year going around to some of the facilities, providing that education. In a more formal setting, we also do education every time that we're in there. So listening to their questions, asking questions, seeing what is working well, what is not working well, and talking about it when we're there. So I've had some bookings for some more education for this year already.
Terrific.
So, which is really, really good. So, and it'll be an ongoing thing because we all know we've been to education and, you remember it for, a little while, but then if you don't use what you've learned, you kind of forget. So it's that ongoing reinforcement of what they need to look for.
Yeah.
Teaching them how to talk to families too, because that's really important. Making sure that the family members are aware that, we do expect weight loss when someone's deteriorating. And, they don't weigh people just for the sake because it's, it's the 13th of the month, so whoever's in room 13 gets weighed.
Gets weighed today.
And that gets put in the computer. But we need to teach them that actually need to look at the pattern. What's the pattern doing?
Yeah.
And you don't just need a dietitian referral because someone's lost some weight. Are they eating less or are their dentures still fitting correctly? And, all of those sort of things. What could the cause be?
So like you've touched on communication. So communication strategies as nurses in general is huge and something and super important in our roles. And in palliative care, it's almost more important because it's often a subject people aren't comfortable talking about. And in aged care, the families aren't always around when there's opportunity for these discussions, say, with us when we're visiting. So is there an area for us to offer and provide like education, advice and support for the aged care staff so that they can have these conversations earlier?
Yes, so in part of the deteriorating patients, I touch on making sure that the families are aware of what's happening. I've also done some family meetings, but I always make sure that they come with me. And then I've offered support so that the next time a family meeting comes up, I can be there, but they can lead the family meeting, that it's supported and so they understand how important it is. And I teach them or explain to them that if the family have trust in what they're doing, they go home with peace in their heart that their loved one is looked after properly. And that's so important because that's their most important person in that bed. Make sure that they understand that, that we all know that you've got, say, 100 very important people in those beds, but for that family member, that's the most important person.
Absolutely.
So they have to understand that when they walk into that room, there is no one else. There is just that person. And when they walk out of that room again, they've got 99 others as well.
Yeah. And sometimes the opportunity for these difficult conversations around death and dying are missed in aged care facilities, and some of that is what we're talking about, the not recognising the deteriorating resident. Do you have advice for staff in that?
I would say making sure you get comfortable with talking to families. So talk to them about normal things. As soon as the resident comes in, introduce yourself to the families. Find out from them what their biggest worry is. What are they worried about when they leave, those sort of things. So if you build up a rapport with the family, it's easier to then say to the family, look, I think, mum or dad is not eating as much anymore. I've noticed that they've lost weight, those sort of things. You've already got that bond with a family.
Yeah.
So building a rapport with families early is really important.
Yeah. And I guess it's also acknowledging where the family's at in the journey too. So we may see that the client's deteriorating, sleeping more, not eating as much. Often, and even we get this in the community with clients, is we need to keep feeding them, we need to keep giving them food and fluids, which is always a tough one and a tough conversation sometimes. What's a good way of approaching that with families around the nutrition change for
I
clients
say
at
to
end of life?
families that, food is our love language because that's what we do. We feed people.
Yeah.
So it's about teaching families that our bodies really know what they need and what they don't need. And as we age and we deteriorate, generally our body knows what we don't need anymore. It doesn't hurt to not drink or not eat. So people aren't distressed. So explaining to families that it's okay if they're not eating and drinking, that we just have to listen to what mum or dad or their loved one wants and what they're needing at the moment. And if their body's saying they need, food or fluids, they will ask for it.
Yeah, it's a common one that we get, isn't it?
It is.
And also them understanding that sometimes giving fluids and things at that end stage of life actually causes more distress and more symptoms of concern. Yeah. So what would you say are some of the highlights so far that we've achieved during our aged care project to date?
Building up some really good relationships with the aged care facilities. They know who we are. So when we come in, it's like they recognise who we are, and they've always got someone else they want to talk about and those sort of things. Seeing staff grow from like really shy and not wanting to engage with us even, being comfortable putting in a subcut line without any prompting or anything like that, with families watching, that's a huge win. Knowing that clients have had a good death, because there is such a thing as a good death, and that families are comfortable asking questions. They're the highlights. And providing the education, that's so important.
And it's already made a big difference to our referrals, hasn't it?
Yes, it has.
From aged care facilities, which is great, which there's 11, is there?
Yes, there's 11 in the Greater Shepparton area. Yep.
Which is terrific, and we've had contact with each of those.
Yes.
Which is wonderful. So do you have any other comments around the aged care and specialist pal care?
I think it's a very important thing to have palliative care in aged care, because everybody deserves to have a good end of life. Staff deserve to know what's happening. I'm in the process of developing some education specifically geared at the PCAs, because they're the ones that see the deterioration first. They may not understand what that deterioration means.
Yeah.
And often they find it hard when the resident aren't eating anymore. They don't understand why it's okay if they're not eating and that sort of thing. So it's important for them to understand. A lot of our PCAs are not of Australian origin. So, and palliative care is done very differently in different parts of the world. So we can all learn from each other and how they do it in their native country. But we are in Australia, so they need to understand this is what happens here and what we can do. And they need to understand that if they notice a change in their resident, how the chain of command works and what to do if that chain of command somehow doesn't work, if no one's listening to them. I say to everyone, anybody can do a referral. It doesn't have to be the nurse in charge or the boss of the facility or the GP. Family members can do referrals.
Absolutely.
The PCA can do a referral, and they don't have to be scared of who they're going to find out who did the referral, because all they have to do is let us know that, please don't tell them, because we won't. We'll just say, well, someone did the referral, can't remember who, that sort of thing. So, but and it's validating what they're seeing as well.
Yeah, and advocating for residents is important. And particularly from the staff at the coalface, who are often the PCAs in this instance.
I've done some debriefs with some PCAs who've had a traumatic death and just weren't really sure where to place that in their life and that sort of thing. So that was really successful as well. They both felt a lot more comfortable in that scenario of what had happened and why it had happened, how it did and that sort of thing.
And I think that's super important, debriefing and acknowledging the loss, particularly in aged care. So often they're almost like family to a lot of the staff, these residents. I mean,
they are.
We ourselves in the community get quite attached to our own clients and don't have them often for half the time people have them in aged care. So there really does need to be that acknowledgement and that opportunity for debriefing.
It does,
about the loss too. So that's another thing that we can continue to advocate for and support them in. So, Marjo, just one last question before you go. If you could change one thing about how society talks about death and dying, what would it be?
We need to normalise talking about death and dying. We need to be the child who thinks, yeah, that's okay. I heard a beautiful saying earlier this week from a client's partner. Grandchildren were in the house when Grandpa was dying, and they'd seen him deteriorate, not communicating anymore. saw the empty bed after the funeral director had been, and the little girl had just turned to Grandma and said, "Oh, is Grandpa in heaven now?" And the answer to that was simply yes. "Oh, cool, I can make him another drawing." So I think we need to embrace the inner child and not make it difficult.
And we do complicate it. So you're spot on there. We do complicate it, but it's 100% guaranteed that it's going to happen for all of us at some point.
That's exactly right.
So I agree. Normalising is a good opportunity. Well, thanks, Marjo, for joining us today on Palliative Perspectives, and look forward to our next instalment.